different than what you usually hear. Most people, we don't take care of our pelvic floor. We are probably going to have issues elsewhere, but we don't know where to look.
Story of the human body and how it works.
I called the book The Musculoskeletal Mystery. It is a mystery to almost everybody, and literally and physically is on the same page, understanding the language and helping each other get that care and treatment. How little this information legitimizes the conversation no matter which side you're on. We don't just look at an organ, we look at the whole body. 5, 10, 20, 30 years, these patients are suffering with conditions.
Conditions do you think are misdiagnosed or misunderstood?
You talked about before, women's health was considered this whole like reproductive maternal care, and that's super important, but that doesn't mean we should ignore the address all of the, how much we treat in the pelvic world. We know where they are in their life, and then what do I need to do to get them back to the highest level of function they can. So you really do have to be creative. You really do have to be a detective. You were speaking of is genitourinary syndrome of menopause, GSM for short. It is replacing the word vaginal atrophy in order to get them to stop having it, right? And a pill's not necessarily going to change that. It may help it, but we work in conjunction. Maybe the pill gets them going in the right direction, and we give them all these great possibilities of how to control it, and they come off the medication, and here each patient gets that individual care.
Well, hello. Welcome to the next episode of the IPZO Facto podcast. I am so pleased to have with me today Ingrid Harm-Ernandes, and she has a very interesting, unique background and career, and I learned about this recently, an area I didn't even know about. So have you ever wondered about your female body and how it works? And new information that actually gives a different way of treating some conditions. And I'm sure you're going to learn some things today that you never knew. So today I'm bringing on Ingrid, and we're going to talk about some of her information that she has shared. She's, I would say, a detective, and this has come through in some of the works that she's put through. She's the author of the book, The Musculoskeletal Mystery. And she's also had a YouTube series called The Pelvic Detective. So this will be a really unique discussion, not your typical healthcare professional dry talk, but by someone who is a creative in her own right. So Ingrid, I'm so excited to have you on the podcast today. And please, if you could introduce yourself so the audience gets to know you and what inspires you most.
Well, first, thank you for having me. And I'm excited, always excited to talk about the pelvic floor, which sounds kind of funny. But when you're in this field, you feel like you really want to get that information out there because so many people do not know what their pelvic floor is and what is involved in pelvic health. So I've been a physical therapist for 40 years, but I've been a pelvic health physical therapist for about 30 years. And there's that big gap in between becoming a therapist and a pelvic physical therapist, because when I started, there really wasn't anything called women's health or pelvic health as it is more known now, because everybody's got a pelvic floor. So we treat everybody. But the interesting thing is it has improved over time, but at a really, really slow pace. And I would love it to improve more. So some of the things over my career have included education on all different levels. And that's education, whether to another physical therapist, to medical practitioners, to lay people. I go to libraries, I go to conferences, wherever I can, where someone's going to listen and try to understand a little bit better what is that pelvic floor and how do I get care for it. We had the first residency program for pelvic physical therapy, women's health physical therapy in the country at Duke. And I've done all different. I've written some papers to try to help other practitioners understand what a musculoskeletal assessment is, because I'm sure we'll go a little bit into that mystery component down the line. And then I also have done some research with different organizations to try to kind of bring to light a little bit more what physical therapy can do, because that's also a mystery and early on was not researched well, and that is improving, but we really need physical therapists to be in there to kind of help develop those protocols. So I've been part of that, which is exciting. But one of my main goals and my main drives really is, trying to get patients and people care earlier, appropriate care, care that helps them live their lives and get back to that quality of life, that, it can be so
Mm.
affected in, poorly affected or negatively affected, right? And people don't know how to ask for that help. So that's what I want to change. I want to change that ability for people to get that help. And that's why I'm so grateful to always go on a podcast and talk about this and let more people know who don't even know what they don't know, right? To really learn more about pelvic health and what physical therapy can do.
Ingrid, thank you for sharing that. It's really interesting, especially as you describe, it's an area that has actually evolved from what I understand in what you've stated. And so as you mentioned, you've been a pelvic floor physical therapist and a detective in that case, because of course this is a new area. So, in that vein, can you share what first drew you to this field and what keeps you passionate about it today, especially in an area that is new and evolving?
Yeah, I would say so. Many years ago, when I was in a private practice setting, I would end up having a lot of the pregnant folks, and interestingly enough, enough of them would kind of confide in me and quietly say, Ingrid, I have this leakage, I have this urinary leakage and I don't know what to do about it. And so I'm going to really date myself, but I had to go to the library to go look up,
Mm,
what is this, what's going on. And then I discovered that in Australia and in some parts of Europe, some physical therapists were actually treating incontinence. And I thought, well, that's interesting.
mm,
And so I learned a little bit myself. I just kind of taught myself some things, and I thought, wow, just these little things already are making a difference in my patients' lives. So as luckily I was up in New York at that point, and the guru of our pelvic world in physical therapy was at one of the conferences, and I took one of her courses. And then over the years, I just took as much as I could, taught myself as much as I could. And then that grew. And I started doing this work when nobody really knew what it was. I would go to the
mm,
doctors and say, look, I can treat patients for all these different things. And they'd be like, what? As if I had lobsters crawling out of my ears. What are you
uh,
talking about? But when they finally sent a patient and the patient did so much better, and the patient's like, why was I not here? Why was I not referred to you before?
mm,
And the doctor's like, wow, this really works. This is really good. Then they would refer more patients, and it grew from there. And then luckily our profession has grown, over the years, and there's more education, there's more opportunity. Our national board has a board certification for women's health. So, and pelvic health. So that's really cool to see many changes. And then, like I said, we have the residency program. Now there are a number of them across the country. So there's more opportunity to learn. But I say what, you were asking what kind of keeps that passion going is the fact that every time a patient walks in the door and I can
mm,
see how they get their life back, that just keeps
mm,
me wanting to do more. And now, because I do more education, every time I do education, and I've done, book signings at farms, you name it, I've done it. And to see people walk up and at first be kind of like, I don't know if I want to talk about this, to like,
mm,
I need your book. And I so, need this help. And then, I go back to the same venue, let's say a couple months later, and someone will say, I got your book. And it made such a difference. Again, to see that that wonderful, wonderful change in someone's life just makes me want to keep doing it more and more, to educate more and more. And I would say that just keeps the fire going, to help people out and to get this education out there.
Well, I mean, so many people are benefiting from this and from your passion, and I think that's just fantastic. And you're really leading from your passion and purpose. How beautiful to have that all combined and so well in what you do in your profession. And your creativity into this as well by how you share and how you educate is in different forms. So we mentioned your book, and so let's start there. So your book is called The Musculoskeletal Mystery. And so maybe let's go, what is that mystery that you talk about? What kind of inspired that detective level as in your YouTube series and mystery aspect that you're bringing into it? And from what I recall in your book, you also talk about patient stories. So not only are you actually learning in the field or practicing and experiencing patients' journey through this type of treatment, through the physical therapy that's applied and with the doctors that you work with. But someone who is curious about this can actually read your book and learn somewhat firsthand in that story of the patient's experience on how this works and how others have benefited and experienced that different type of treatment. And I just want to double down here because you talked about women's health a couple of times, but I think you also mentioned back in the day, no one mentioned women's health, right? I mean, really, if you think about it, it's relative, but it's very recent that anyone's really talking about women's health, and how we're defining women's health has also evolved. So when you started, there wasn't such a thing as women's health, and it was more, I guess, reproductive, limited to that thinking. So, as you describe your book and the mystery, as I mentioned, can you also just pause for a second and talk about what the pelvic floor, like, just for the audience to kind of orient, what is the pelvic floor and what does that mean? And then we can get into your mystery and detective story from there.
Yeah. So the pelvic floor is basically, I like people to think of it as a bowl at the bottom of their pelvis. So kind of from the tailbone to the front, what's called the pubic bone is a sling like this, kind of more or less. So we have to think of that as a hammock and a bowl, like I said, where
Mm,
if that hammock is working well, those muscles hold all the organs up and hold everything up, no matter what you do in your life. And if that hammock isn't doing a good job, it's kind of like a hammock that hangs down. So if you imagine like you've got a hammock that's very loose and you go to get in the hammock, your bottom's going to hit the ground, right? So I like people to
right.
think of this importance of this hammock or bowl idea, right? So it's three-dimensional. That's all muscle. All right. And here's the funny thing is
Okay.
people don't think of muscles as being part of pelvic conditions. No, it's my bladder, it's my bowels, it's my uterus, it's whatever. But no, this pelvic floor is the key to our pelvis, really. And so what I like people to think
Mm,
of is this is all muscles. And these muscles have many jobs, many, many jobs. So they have the support that we just talked about here, this feeling like everything's being held up, right? So if I cough or I sneeze, my pelvic floor has to be able to respond. If I lift a weight, my pelvic floor has to be able to respond. So it's active all the time.
right.
Yeah. Then there's a sphincteric function. And what that means is we have muscles that form sphincters, so open and close like this, right? And for our pelvic floor, some of them are what are called voluntary. That means that if I don't want to pee, it's closed. If I do want to pee, it's open. So we can control that. Same with our bowel. And then sphincteric, we go to sexual function. It's got a very important sexual function. It allows us to have intercourse. It allows us to enjoy intercourse. It's all part of
Mm.
that whole sexual function, right? And then we have a what's called a sump pump, I'll call it. It actually helps pump fluid out of the pelvis, right? So we don't have a congestion of
Okay.
fluid in the pelvis. So we're already going through numerous things that the pelvic floor is responsible for. It also has
Wow.
this kind of support in a different way, stabilization, which means that it links to our whole core. So I talk about the core very different than what you usually hear. Most people
Yes.
say, well, my six pack is my core. Well, no, that's like the most minimal part of our core. The abdominals are a whole series of abdominals, with the rectus, the washboard look, only being one tiny bit. Our transverse abdominis
Mm.
is like a natural corset. It goes around our whole abdominal area and inserts into our back and works in tandem with the pelvic floor. So when our pelvic floor works, our transverse abdominis works like two sisters holding hands, right?
Oh.
Yeah. And then if we move to our back muscles, they also work in conjunction, and our muscles
Hmm.
work in conjunction with our pelvic floor. And then our diaphragm. So what we breathe from is also a muscle. And every breath we take influences the pelvic floor and vice versa. So when you're breathing properly, you're actually getting your pelvic floor to work. So
Ah.
it's a
Wow.
whole structure. And then what I'll do is I'll take it one step further and say that I want you to think of your core as your house or your apartment complex. And when you when your foundation of your house or your apartment starts to crumble, something else is going to have an effect. So in other words, the rest of the house or the apartment might start to collapse because the foundation isn't there for it. So if we don't
Mm.
look at the foundation, our pelvic floor, and we don't take care of our pelvic floor, we are probably going to have issues elsewhere, but we don't know where to look. We don't know to look
Right.
at the pelvic floor as the
Yeah.
origin of the issue. And on top of that, the pelvic
Okay.
floor is a birthing. So it's a breathing process and a birthing process too. So I just named something like 7 different functions for a pelvic floor, yet
Yeah.
nobody even knows what to ask or even knows that these things are interconnected, and that if we treat our pelvic floor well, we're going to be able to treat our body well, right?
Wow. I just learned many things I didn't know. And I thought I knew the anatomy pretty well. Wow. Okay, that's really interesting. So I can see how you kind of took the mystery detective route here. First of all, I think it probably makes it a lot more interesting. Just as you described just now, it's very engaging. You're telling a story of the human body and how it works. But in so doing, in all these different ways that the pelvic floor um, connects and integrates with the body, it's with so many different functions you just mentioned, and so many different activities. And so, is this kind of what inspired you to take this tact approach in describing?
Yeah, yeah. So I would say, I called the book The Musculoskeletal Mystery basically because it is a mystery to almost everybody. And this is lay people and professionals,
Yeah.
medical professionals. It doesn't matter, like, to be able to put that all together, to integrate it in a function rather than just this is the anatomy. But no, this is the story, exactly like you said. And this is why it's so impactful. So when I wrote the book, I kind of thought, how do I approach this to make it understandable? And I thought, well, how do I educate my patients, when they're in clinic? And that's how I educate my
Mhm.
patients, just telling them this is how it all works together. And I would see these amazing light bulbs just go off.
Yeah.
And when I started to present and do a lot of education, I would see the same things like, oh my gosh, I didn't know what I didn't know.
Yeah.
It's such a great thing to see people make those connections. And then I added, how to solve your pelvic floor symptoms, because I wanted people to say, well, if I understand better what's happening in my musculoskeletal system, I understand better why I could have an issue, and I understand better how I need to get it treated. So the book follows that process of, this is the musculoskeletal system. These are the conditions that you may have. This is what might happen in a therapy session. This is how you can help yourself. Like, I just made it flow like that, so everybody, no matter who you are, you can take that book and go into the doctor with you and say, this is what's going on. A
Oh,
doctor can say,
yes,
this is what's
right.
going on. It helps everybody be, I call it on the same page, literally and physically, is
Yeah,
you know,
literally.
on the same page, understanding the language and helping each other get that, that care and treatment.
So, you just brought something forward that I didn't think about, and first of all, I'll say, um, people should look at your book to understand this because there are, a variety of different impacts with the pelvic floor, and understanding that can help you understand um, what options there may be for you. But really, like you just said, to have that conversation with your physician, and the way the book is presented, um, the hard copy is so nicely presented, so easy to read, and you have very good descriptions in there. So I think I encourage people to go take a look there, and you're bound to learn something that you didn't know, but in particular really looking to see, maybe you see yourself in the descriptions of some of the patient journeys and stories that are there. And so with this book, who would you say it's written for? Is it you just talked about how the book could be used. So I guess it can be used with clinicians, or clinicians on their own to understand more as well on how to talk with their patient, or so really looks like the audience is quite broad. But when you were writing it, what was your intent of the audience?
Yeah, so I thought, my first thought is, I want to help patients understand what's going on. But, as I was writing it, I thought to myself, no, when I've done education, and I'll go way back, quite a number, 20 plus years ago, I was to do a talk on pelvic health and pelvic physical therapy for physicians and nurses. And the physician that I was working with, who invited me to do this in the Bahamas of all places, said to me, are you nervous about it? And I said, I'm not so much nervous, but like, I'm concerned I'm not going to be able to really educate them. What do I have something to offer? And he said, they have no idea what you're going to talk about. They've never learned this before. It is not in medical school. It is not in nursing school. It's
Yeah.
not anywhere. And, when I did that first talk, a lot of what we just talked about, similar stuff, they just hammered me with questions. Oh my gosh, what about this? We didn't know about that. This is interesting. Can you explain it more? We just don't, we aren't taught this. And it really taught me how little this information is out there, right? That's what kind of really started me thinking, this education needs to be for everybody. So everybody is on the same page. Like I was saying before, that a physician
Mhm.
or a nurse has it in clinic with them and can explain something to a patient, or a patient can have that book, put it in their purse, go in and say, look, this is what I have. Can I get help for this? Right? It legitimizes the conversation no matter which side you're on. And it gets everybody saying, well, there are many ways to look at this. We don't just look at an organ, we look at the whole body. And that's one of the things I talk about. There are
Mm.
two main, I guess, advocacy groups under this pelvic health. Is one is more that, hey, we need to talk about it, right? We need to get the information out there. But it's also, how do we help others? How do we talk about it in a language that other people can get help too, right? So we want to
Mm.
make sure that we're capturing everybody, and that's what the book does. It lets everybody feel brave. It lets everybody say, I can be part of this, and it lets everybody see, wow, if I talk about it, it's not just myself that I'm helping, but hopefully thousands and thousands and thousands of other people.
Yeah, amazing. And here you think with the advancement of medical care, what other than kind of very deep cellular level, genetic level, you know, you would have thought anatomically everything was kind of known by this time in 2025, but actually that's not the case. Maybe that was my naivete, but um, you described, how uh, patients first came to you, right? And they were a little bit shy or hesitant to talk about things. And so you mentioned, I think, also about this as the hidden body part. And I guess with the book, what that enables is what you just said is it's enabling people to have that conversation. Like you said, it legitimizes, and so maybe it helps people to speak up and describe using words and illustrations and such from the book that they wouldn't have otherwise known how to describe what they're experiencing, or how to ask the physician about, is this something that's going on here? Let's talk about this, right? And kind of describe their condition. So I think that's really powerful because you're kind of bringing the invisible to become visible.
Yes. Yeah, exactly. Yeah, we want to make sure because I mean, when I was working clinically, I'd say 5, 10, 20, 30 years, these patients were suffering with conditions. And it was
Mm,
frustrating to see that it was either they didn't know what to ask for or the provider didn't know to offer physical therapy, right? So it was so frustrating that
right.
I thought to myself, I can't stand by anymore. And patients had been begging me for years, please write a book. Everything you talk to me in clinic, everybody needs to hear that. They need to hear your voice and how you're describing these things, which is also what helped me with the format of the book is my patients really are
Okay.
who told me this is what we need, right? And then the clinicians started
Yeah.
saying to me, Ingrid, please, talk about this, do this. And so it was really cool that on both sides, I'm getting this encouragement to say, let's get a better job of explaining these things out there so people get care. So I would say that frustration that the patient had, that I had of them not getting care is what really, really pushed me,
Mm.
to write the book and to get that information out there for everybody.
Yeah, incredible, Ingrid. And so, given that in the situation where it's not taught in medical school or hadn't been, right? I think it's beginning to, as you stated, you've engaged with some curricula. Um, but when you think about dysfunctions that are caused by this area and the muscular um, impact of conditions, which conditions do you think are most often misdiagnosed or misunderstood,
Mm.
even within the medical system as it is today?
Yeah, well, unfortunately, all of them. But quite
Okay.
honestly, so even something as straightforward as you think is urinary incontinence. So that's out in the media more now. People are talking about it a little more, which is kind of good. It's kind
Mm,
of that introduction into these are pelvic conditions. But people don't understand I'll give you an example, overactive bladder. You hear all about medications for
mm,
it, this, that, and the other thing. But what you don't hear is that oftentimes the pelvic floor is what is creating or adding to the overactive bladder. And it's not truly just a bladder issue, it is also a pelvic floor issue. And there are many things that we can do at the pelvic floor, at the abdominal area, even in the back area that help reduce these overactive
mm.
bladder symptoms. And
Okay.
eliminate medication. I've had many patients who come in and they're on all these medications and we work on things and they can come off the medications, right? So that's just like one example of something that's a little more heard about, but still a mystery. And then things like prolapse. So prolapse is basically a protrusion of one of the organs through the vaginal canal that creates like a bubble at the vaginal opening. And unfortunately, many people freak out. They think they have cancer, what's growing there, and it's really this protrusion, right?
Oh, right.
That's a big mystery for people, and the pelvic floor is really important to
Yeah.
engage early in life. And then another thing, another
Okay.
huge misconception is that during pregnancy and after pregnancy, it's okay to have pain, back pain, pelvic pain, incontinence, constipation, fecal incontinence, that these are things that women who are pregnant afterwards are just told, hey, go live with it. Women have been dealing with this for centuries. I'm like, no, this is not so. We can get that treated. And if we get it treated earlier in life, we help as we progress through life. What I call the continuum of life, which isn't just the reproductive component, which is what you talked
Yeah.
about before. Women's health was considered this whole like reproductive maternal care. And that's super important, but that doesn't mean we should ignore the perimenopause or menopause transition time frame and the menopause and postmenopause. We really need to address all of these components of our life in order to realize, well, if we treat everything early on, we're less likely to have the risk factors later in life for it, right? So that's another thing. And then constipation.
Mhm.
People think, oh, that's just my bowels. Well,
Mm.
no, the pelvic floor has a huge influence on our bowel movements and can be the cause of constipation if we don't know how to treat it properly. And then lastly, I'll make this
Oh.
a big, big category that's split into two. One is pelvic pain, and I'm going to put sexual dysfunction
Mhm.
and pain with sex in under that is something people do not want to talk about. And we really need to talk about it. And it gets blamed on dry tissue and low estrogen when a lot of times it's tight
Yeah.
or musculature. And then pelvic pain is a large, large category all on its own that encompasses hip pain, back pain, pain at the pelvic floor, abdominal pain. It's all in there. It's
Mm.
a huge, huge category that even endometriosis, which you think, oh, what can pelvic PT do? Because that's a growth of endometrial-like tissue. So the lining of the uterus, for those who aren't familiar with it, the tissue that is like that lining can grow outside the uterus and in the abdominal cavity and over our fallopian tubes and all over the place.
Mhm.
And although that's a growth, the secondary musculoskeletal issues that grow from that can very well be treated by pelvic PTs, right? So conditions people do not point
Interesting.
out, yeah, there are many. I mean, I could spend 3 hours just going over all the conditions, but that's in a nutshell, how much we treat in the pelvic world.
Yeah, that's really, really interesting, Ingrid. And I guess it makes sense because I'm so glad I asked you to describe the pelvic floor because that's giving a good context to everything you're talking about. So in how you describe the floor and the core, um, actually there's so much integration, right? That okay, it kind of makes sense now on how that, like you said, it could be direct or it could be secondary to some of the conditions you talked about that can be treated through physical therapy. But now, what just came to mind is physical therapy as a profession, as a treatment approach, in and of itself is an integration, right? So um, you don't just take the diagnosis into consideration. You're kind of looking at the uh, condition as a whole. So can you describe from a physical therapist lens how this is different um, than a traditional treatment lens of maybe pharmacological or surgical or otherwise?
Right, right. So we look at things in a functional capacity. So what I mean by that is instead of taking a diagnosis and saying this is the diagnosis and I'm going to treat it because this is what the diagnosis is, we're saying this is what's happening with the person and we want to bring them back to their ability to do their daily routine. So if I kind of
Okay.
clarify that a little bit, it would be I might have two people coming in that have urinary incontinence as their diagnosis. but I may treat them totally differently because they're different people.
Mm,
So one might be, a mom with 4 kids and a job, and she's running here, there, and everywhere. And the other one might be, a retired lady who's 72 years old. She has a little bit more time. She likes to garden. She's still very physically active, but her life is very different. So I'm going to create a plan that lets them get back to their life where they want to be. So for me, once I get through
mm,
my whole subjective and I ask them all questions, and we take like a half an hour. And in the book, I describe this like we take a long, long, long time to really say, what are you? Where are you as a person right now? And what affects your life? If they have incontinence, I'm still going to ask them about sexual issues. I'm still going to ask them about bowel issues. I'm going to ask them about their past pregnancies. I'm going to ask them all these questions
mm,
because it lets me know where they are in their life. And then what do I need to do
mm.
to get them back to the highest level of function they can? So you really do have to be creative. You really do have to be a detective. You really do have to figure things out, like to wrap together what you were saying before.
Mm,
As a physical therapist, we look at it from that capacity instead of a diagnosis, right? So it doesn't constrict
okay.
us down to one thought of this is how we're going to do it. Instead, it's like, oh, I can do this and I can do this and I can do this. And guess what? I'm going to talk a little bit about the interdisciplinary care role because it's a big
Yeah.
thing we're always talking about is I might say, let's say it's a sexual issue. I might say, hey, we can do this, this, and this, but we need a sex therapist in here. We need a urogynecologist to look at what's on
Mm,
the medicine side of things, right? We need an acupuncturist, right? And I'm going to pull all these other disciplines in to say, we need to look at all these different aspects if we truly want to treat you as a whole person and get all of this resolved.
mm.
Right. So I think that's the difference with, physical therapists and the medical profession is we're like that center spoke. And I've been yelling about interdisciplinary care for decades. And it's a slow go. It's getting there. It's a slow go. But we really need to look at our people that way. It's like, how do we treat them
Yeah.
on many levels, not just this is their diagnosis and this, I'm going to put my blinders on. That's how I treat them.
Yeah, amazing, Ingrid. And you were practicing interdisciplinary care before. I guess the term was even well defined. And the other thing, um, from my perspective, it's only again kind of recently that you hear people talking about whole person health, right? And uh, it, as an actual goal or looking at patients or people on beyond one lens alone, because someone can be, as a description I like to use, is they could be a diabetic but they could also be an athlete, or they could have some other sort of condition. But we tend our healthcare system historically, traditionally, has tended to label people based on the disease or condition they're in just that, as you said, that kind of really narrow scope, right? But as you're bringing forward, um, you're kind of expanding my lens, my scope here on this whole person health, and how you're describing physical therapy lens and that into disciplinary approach, which is, I mean, that's so critical because, as you say, it doesn't just work alone. It has to integrate with everything else. And there are, the physical function, but there's also physiology, there's pharmacological, maybe interventions. There's so many different aspects that can be brought in. You even mentioned acupuncture as well. So really interesting. And I think the way you described just now, and we'll maybe double down on this a little bit later, is this customization. It's very personalized, it's customized, just because it has to be, right? This is what you need to understand on how to, what methods of your physical therapy approach or other disciplines that need to be brought in, but you need to understand the whole person, their history, their other conditions they might be in, but even their lifestyle, so that if there are things that they can do at home or in their daily lives that help them to improve, you need to know, well, what are they actually capable of doing? And can they integrate that? Another integration, can they integrate that into their own lifestyle?
Mhm.
So, really interesting. I can see why you have to take a lot of time to really understand the patient, not just the condition that they're coming to talk to you about, but you know, the whole person. Really, really interesting. And so, as you mentioned, the interdisciplinary approach. Let's kind of dial it back a little bit on, um, given that this is a very specialized area and an area that's emerged, right? And you mentioned earlier in one of your earlier presentations that you gave that many in the audience were saying, "Well, we've not learned this in medical school, so tell us more." So, yeah, I like to get your view on, as more and more people are learning about this, um, but the awareness, it seems, is still something to be scaled, I suppose. So is that true? And what education and awareness do you think it's necessary to coordinate with the interdisciplinary approach? Because if physicians, nurses, clinicians, uh, how generally are they aware of physical therapy as a whole in terms of how it can be integrated and where it can be used? But now you're talking about a specialized area of physical therapy. So what's your view on the education awareness, and how do you bring in that interdisciplinary approach in the sense that, um, for the other disciplines to actually accept um, what uh, what you can provide in your sessions, but interdisciplinary means you're working as a coordinated team. So
Yeah.
how do you get how has your journey been on those disciplines, inviting a specialized physical therapy, and kind of that give and take in treating each patient?
Yeah. So not an easy road because when I started, like I said, a lot of people thought I was absolutely crazy for saying I could treat them. So the first step was just to convince them that it works, right? And when I convinced them that it worked, they would ask some more questions. When I came to Duke, what I was really, really fortunate about is that we had so many different types of clinicians treating so many different things, but it still to me seemed scattered in that, well, you have mental health care here and you have OB/GYN over there and so forth and so on. So
Mm,
what I realized I needed to do is the first step was doing even in services. So I know that sounds funny, but I did in services for our own physical therapists in our own department to describe what we did so that they would be better. So the example would be an orthopedic physical therapist would be treating someone with back pain and they were not getting,
oh,
and then I would say, so if you feel like, and I would
okay.
give them some screening tools. Do you feel like this may be an issue? They would then refer. And after a while, it became easier. They'd say, hey, Ingrid, I've got this patient. I think maybe they've got some pelvic floor issues. Would you do an assessment? And then we would work, I would say tag team. We would work together to get that patient better. And then I took it the next step and I did work in services with our OB/GYNs, with our urogyns, with
Mm,
so forth and so on. Then I took the next second and I did step and I did grand rounds. So now it's educating,
okay.
200 and 300 physicians and fellows and residents at one time. And then we took it a step further and we opened a clinic within the Urogyne clinic. So a couple days a week, physical therapy was happening in the Urogyne clinic, which was amazing because I could run
Uh-huh.
down the hall, or they could ask me a question, or I could jump in with a patient if I needed to. And we really started to coordinate the care. And then I started to learn more about who are acupuncturists and go do in services for them. Then the next step was have them shadow in clinic with me while I was treating. And the
Interesting.
fellowship program at Duke, a requirement is that they spend not just their third year, which is where we started, but all 3 years in clinic with us a couple days each year. And it blew their mind. They were like, I totally understand now why I need to send a patient over to you. It was not clear until I was in.
Uh-huh.
So then we got OBGYN residents to shadow with us. So what happens, and there are some larger organizations now that have their fellows and their residents shadow with pelvic PT. So they're in the clinic and they see the response, they see the change. So all it took years, years and years to develop that. And then I started realizing I need to get on bigger stages, talk more, do all of this. So once my book was published, I went out there and, whether it's doing a podcast or doing an educational session or whatever it may be. So I think education is key, but you have to be so willing to
Mm,
continually be after it because people still don't know what they don't know. That's still something that I'm coming up against. And now
yeah.
what's worse is social media can be beneficial and it can be awful because it can really
Mm,
spread very wrong information or it can spread good information, but a lot of times it's just from one lens and one idea instead of like a broader spectrum. So I feel like I spend a lot of
mm,
time answering on people's posts, and I'm not a social media person. I don't really care for it, but I realize it's important to help get good information out there. So I try to be that person that is like making people think a little different, think outside the box, so to speak, and just get that information out there. So that's kind of that rough road to getting it out there. And there are other pelvic health therapists trying to do the same thing. Really trying to get some good
mm.
information out there. And I see it going in a positive direction, slowly but surely. I would love to have it go much faster, but it is what it is. So we just keep plugging away.
That experiential aspect that you mentioned when, with the in-services, um, how amazing that must be because you see the lights come on and you described someone saying, aha, now I understand, which patients might benefit. I mean, that's pretty amazing and game changing because, um, you know, some of the so-called traditional therapies or other therapies that were used in the past may not actually be correct or right at that time. Or maybe it's okay, but there's a different way that maybe will be more comfortable for the patient overall. And so you mentioned about how people talk about this and how that's changed, right? There's new terminologies, and this is a different area. And there was a paper that you mentioned to me that came out last year, I think. And there's different terms that are used. And in the paper, there was a term called, vaginal atrophy. So could you kind of maybe explain, um, first of all, maybe describe what that paper was, and we'll include things. It will include all information in the show notes so that everyone you can benefit from the information that Ingrid is sharing, but also with this paper because I was really interested in the different uses of terminology now, and also just musculoskeletal as well. So could you talk a little bit about that?
Yeah, yeah. So that has a twofold part. So what I'll say is, what you're speaking of is genitourinary syndrome of menopause. So it's a mouthful,
Mhm.
GSM for short. It is replacing the word vaginal atrophy, and I am so glad it is. So GSM was first kind of talked about a decade ago, roughly 2014, 2015, somewhere in there, where it started. That's where you'll see those first
Mhm.
mentions, but really didn't gain traction until a little more recently. And basically, it means that someone who has this, it's not, so vaginal atrophy just sounds like the vagina is kind of, falling in on itself. It's
Yeah,
terrible. It's not what's
right.
happening at all. Or my
Okay.
tissues are dry. Really what it means is this syndrome is, it occurs more likely during menopause transition and menopause. That's the most likely time for it to happen. And it involves our
Mhm.
bladder, urinary symptoms. It involves the vaginal tissue. It involves quality of life, right? So that's what this term kind of encompasses. The paper that you asked
Okay.
about that was published last year is the musculoskeletal syndrome of menopause, which I was so excited to hear about because they're talking about the musculoskeletal system finally. Yay. But there are only
Mm.
about 2 lines in that paper about GSM, which means although they're talking about the musculoskeletal system, they're not really talking about the pelvic floor. Now, I had the great privilege and honor to speak to one of the authors of the paper. Luckily, so I was introduced. We went to an M Factor. She coordinated an M Factor, which is about menopause screening. And I was one of the panel members. And I talked to her a little bit. And I said, hey, GSM, it's pelvic floor, it's musculoskeletal. So they are now looking at their next paper, including more about the pelvic floor, which I'm thrilled, absolutely thrilled about.
Aha.
But to take it back to the musculoskeletal syndrome of menopause, the reason why that's important and why their paper is groundbreaking, is because it talks about the fact that we have things like joint pain, joint stiffness,
Mm.
frozen shoulder, hip pain. We have
Mm.
muscle mass loss. We have bone density loss during this time frame of our life. And as we go through menopause transition,
Mm.
which by the way happens a lot earlier for many women than people think. It can happen in our
Mm.
40s. Some people as early as 35, which is kind of a premature menopause transition. Just a side note, but 40s to 50s. And then menopause and postmenopause continues the rest of our life. So we are talking about decades of life, not just 1, 2, 3 years. This is many years. And
Right.
in this time frame is when some of these changes accelerate. When we lose estrogen, some of these problems accelerate, right? So instead of just aging, they suddenly get much worse. So now they're looking at, why is it? What do we do about it? How do we address it? So they've named it. Now we can talk about addressing it. And that's why this is, I think, going to be such a landmark paper, is that it's looking at things very differently. And my hope is looking at the physical, the musculoskeletal, and all of that as being such a huge part of menopause transition. And menopause, it's not just hot flashes. That is the tip of the iceberg, or the
Yeah.
volcano, if I may say. That it's a small part of it, that even studies are showing that physical exercise and activity can reduce the amount of vasomotor, so hot flash symptoms, that someone has. So
Mm.
if we, go to physical therapy early, and we learn things earlier, and we learn how to take care of our body earlier, we can actually help ourselves with these menopausal symptoms that people think,
Mm.
I'm just going through menopause. I can't do anything about it. No, there are tons of things that you can do for muscle mass, for bone density, for cardiovascular
Mm.
health, for pelvic floor health, all of that. People shouldn't feel like they just have to put their hands up. No, there's so much we can do for it.
So, really, what you're talking about here is empowerment. It's empowering the individual. Um, as you say, traditionally, it's kind of throw your hands up in the air. It's like, okay, it's that time, and it's a fait accompli, and however, it's the luck of the draw how how mild or intense the transition
Right.
will be and experienced differently by everybody. But traditionally it's like, ah, well, it's just menopause. And actually, that might be what you're told many times. Oh, you're just going through menopause, but and treat the symptoms or alleviating symptoms. You feel kind of there's nothing else you can do about it.
Right. Right. And
And
unfortunately,
and
it's not true. There is so much that can be done, but people don't know what to ask for.
yeah, yeah. And so for someone who may be kind of struggling silently, right? Whether it's life transition, menopause, or other types of pain or pelvic pain or other conditions that they really haven't um, found answers to yet. Um, what would you say to these people? How would you advise them to um, kind of approach, where to go? Because it could be some have gone to their GP, and GP might not be necessarily a specialist in this area and may not have learned, yet about, um, gone through the programming and such that's being made available, but that might not have been something they've integrated with yet. So from a patient side, um, and someone struggling, and uh, things have not worked for them, right? And that sense of empowerment feels lost. What would you suggest?
Yeah, so stick with it. I know that sounds like okay. I'll try to stick with it, but what does that mean? So basically, there are practitioners now that are getting certified in menopausal health, like perimenopausal, menopausal health, and there are a couple different programs. The National or now it's the Menopause Society, and another company called Peri, an organization that has for years since the 1990s really tried to educate people on perimenopause, are having certification programs so that it doesn't matter who you are, whether you are in family medicine, OBGYN, you're a nurse, you're a doctor, you're a nutritionist, you're medical, excuse me, a mental health care. All of those can be certified in these programs. So some of the things that I'll tell
Mm,
people is if you're not getting the answers with that first practitioner you go to another practitioner. It really, there's nothing wrong with going to a couple different practitioners to try to find the one that has the answers for you. Because if you're talking about menopause and the immediate reaction is either oh, live with it, or b, go take hormones. If it's like this like one
right.
or the other, then there should be a question mark. Maybe I need to talk to someone who's talking about me as a whole, that's talking about many different ways, from my diet to my activity level to my pelvic health, right? If they can talk on all those points, then it's more likely you have a practitioner who's really going to be able to help you with different things. So it sometimes it takes a little sleuthing, a little bit of detective work yourself to find those
Yeah.
specialists. But really do try to see if you can find someone who at least has in there. These days, most of them will have descriptions as to what they specialize in and what they care about.
Hmm.
Look at those, see if menopause is really, or is maternal care, or whatever it may be, do they really have a passion about that? Do they really want to work on that? Are they certified in some kind of menopause care, if we're talking about menopause specifically? But don't give up. I know it can be frustrating, but please don't give up. In my book, I've got a ton of resources. Go on, there are different websites that are reputable.
Okay.
Don't do the Dr. Google search, because the Dr. Google search can put you down a pretty bad path. But reputable sites
Okay.
to say, oh, okay, now I know what's available. Now I know the terminology. Now I know what it really means. Now
Hmm.
I'm armed with the education to go into the clinic to say, this is what I've learned so far. What do you think? Like, I never say, go tell the clinician what to do. You're hopefully going
Right.
there for them to help you, but instead to say, I've learned this. I have this education. What do you think about
Right.
it? What are your suggestions for me to do now? Right. So you're working as a team member talk about an
Yeah.
interdisciplinary care model. You're the patient
Yes.
part of that team, right? You've done your due diligence as
Yes.
well. And then you're asking for an expert to say, what do you recommend? What are your thoughts based on the information I've given you, right? To look at it that in that capacity instead of just waiting for an answer to come in to you. You're saying, I've got this information. What can you now do for me? What are your suggestions?
Yeah, and that's so important for patients, I think, in this case, and just generally overall, right? No matter what you're maybe concerned about or maybe suffering from, is really to be engaged with your care and ask questions. Don't be afraid to ask questions. Understand what's happening, and by having that dialogue, there could be other approaches that might serve you better. So I think what you mentioned about even lifestyle aspects and other things is, be bring those forward. If something you think is not actually going to work for you, have that conversation, and there might be, a customizable approach or something else that your healthcare professional could help you with. But if you don't ask, you'll never know. And if you don't engage, well, engagement is kind of bringing that empowerment forward. I think that's such a good point. So when you talk about the sessions that you do, and you started to describe this earlier in our conversation, but what does a physical therapy session look like?
Yeah, I'm so glad you asked that question. And the reason being is so many patients are afraid to go to pelvic PT, or they just don't understand it. So they're like, yeah, I don't think I want to do that. Right. So if that person understands better what is going to happen, they're much more likely to go. So physical therapy
Mm,
session, we take that the from the playbook of all physical therapists is we're looking at getting activity and function and motion back. So we do exercises and we do manual techniques, whether that's stretching or what's called mobilization, getting the joints going, reducing pain,
mm,
myofascial techniques, getting scar tissue going, all of that. We do all of that like all other physical therapists do. But what is very different for us is that we then look at the pelvic floor function by verbally going through things at first, and then we do an assessment. So the assessment is can be an internal assessment to figure out what's happening in the musculature inside. So what I mean by that is, remember the bowl that I was discussing, right? We actually look at the
yeah.
individual muscles of that bowl to determine what muscles are doing what are not able to do
Mm,
what they should do, what are too tight, what are too weak, and we assess what a
mm,
true pelvic floor contraction is. And I spend something like 5 or 6 pages in my book going over pelvic floor contraction and relaxation because I want people to understand what a
mm.
true pelvic floor contraction, a Kegel, and I ban the word Kegel
Yeah.
from my clinic because there's such a misconception what it is, right? I've assessed thousands of people who've said, oh, I've been doing Kegels for years and they don't do anything. And when I assess them, not only are they not doing it right, they're doing it such that they're making their symptoms worse. And that is key.
Wow.
So we really need to figure out what they're doing. And then from there, we prescribe an exercise program based on that assessment so that they're doing a contraction that they're able to do. They're doing a relaxation that they're able to do, or maybe they're not doing a contraction at all initially because it's not appropriate for them, right? They have to learn to relax their pelvic floor before they can learn to
Mm,
properly contract their pelvic floor. If someone's arm is like this, I'm not going to have them do 1,000 bicep curls like this. I'm going to have to teach them how to open their arm up fully before they can really use that muscle 100%, right? Now, some folks won't get an internal exam if it's not appropriate, but I'm just saying for a pelvic
mm.
PT session, a lot of times a pelvic exam is that starter that we really can learn what's going on. And
Okay.
then we take that information and send them home with a program that is appropriate for them. And then we may do things like we might use what are called dilators because that teaches them how to
Mm,
stretch their own pelvic floor, reduce trigger points in their own pelvic floor, become like a master of their own program so that at home they can duplicate what we're doing in the clinic. And that's super important because we want them to be independent. We want them to be able to do what they need to do in their life without having to rely on, therapy over and over again, right? So that's really important as far as that aspect of it. We may do biofeedback, which hooks them up to either
Mm.
internal sensor or little external pads that records the electrical activity of the pelvic floor. So on a screen, they can see if they're
Wow.
doing a contraction or a relaxation, and helps them build the confidence to actually do it correctly, and have a little fun doing it. Sometimes it's a graph, sometimes it's a rosebud opening and closing, or a space shuttle docking. There are all different fun things we can do with that. So there's a way for them to learn a little bit better what's going on with that. And then there's a big compartment of pelvic PT that is what we call behavioral changes, which sounds kind of funny, but
Mm.
basically means, I'll give you an example: urgency. A very common difficult issue for someone who has urgency is they're out and about, they get home, they put the key in the door of their house, and all of a sudden they have to go. They just, I have to go. And I say, well, your bladder hasn't filled in a nanosecond, but your brain says, there's a safe, clean bathroom on the other side of that door. And every time we go home, we have to run for the bathroom. So, kind of a Pavlovian response, I'll call it, is the key means, the
Aha.
door means I have to go. And after a while, it gets so overwhelming that they start to leak, right? The urgency is so strong that they start to leak. So, we have to teach them how to overcome this brain to pelvic floor and bladder pattern in order to get them to stop having,
Wow.
right? And a pill's not necessarily going to change that. It may help it, but we
Yeah.
work in conjunction. Maybe the pill gets them going in the right direction. Then we give them all these great possibilities of how to control it, and they come off the medication, and here we are. So we've done even a teamwork with the pharmacist in that way, is that we're saying, hey, there are all these things that are happening that maybe you need to, as a starter, but then we're going to work our way to improving it so you can take care of it yourself, right? So it's so multifaceted. There's so many components, but if I had to like
Yeah.
put all those different things together, those are the main things we'll see. And each therapist approaches it from a slightly different lens and starts on things maybe a little differently, but each patient gets that individualized care
Mm.
based on what we found and what they can do or what they are having difficulty doing, and feel like I can't I can't do this now in my life. I can't even work anymore because all I'm doing is running to the bathroom,
Yeah.
right? So it's important to get those
Yeah.
what seem like funny little things under control, because they're not so funny for the
Mm.
person.
Yeah, and I guess something like that, many people might think, oh, it's just, I'm getting old, or, I'm just, I have to deal with it. I have weakness, and I've just got to run, and but actually there is something you can do about it, and lots of people actually may not know that. And I think we've learned so much in the last few years, especially I would think also during COVID, is that behavior impact on healthcare, right? On how we live, and the day-to-day activities that we do, or those activities that we stop doing, and what impact that had. And so, whether it's mental health and otherwise, and even now you're describing a whole other way of looking at biofeedback in this case. So really, really interesting. So Ingrid, you've already covering a lot of things, and you've had all these interesting projects with your book and your podcast series, and your YouTube series, detective series, and then all of the speaking engagements you do, and the in clinic sessions, and it just you've gone through just a phenomenal amount of things, and all of these aspects are ongoing. It's not like, okay, it's kind of done, right? You've started it and it continues. But if I may, what's next for you? Do you have other projects or training programs or resources that you're developing or maybe redeveloping?
Yeah. So I was so honored to do this great thing called a micro series with the National Menopause Foundation. So they're an organization that really looks to educate people everywhere on pelvic floor issues during menopause. And this micro series is actually available to anybody. If you can get on a computer, go to the library, your own computer, and look up the National Menopause Foundation. These micro series are available. And I was one of those micro courses that you can take in there. And that's up and running
Ah,
now. So it was so much fun to do. And I learned so much from my colleagues, and just an exciting thing for everybody. What I'm working on now is, and it should come, be live any day, is Perry, the organization that I mentioned before. This woman has done amazing work in the perimenopause space, and it's a certification program for all practitioners. It does not matter what
mhm.
you specialize in. You can take this perimenopause
Okay.
course, get your CEUs and CMEs and the credits for it. And what she did is, each one of us has a module within it. And then we just finished filming 2 case studies, so that if you sign up for the certification program, you also get to listen to us look at a case study from each one of our lenses. So that interdisciplinary care model that I was telling you about, which is why I was so excited to
Mm,
do this with her, is it really looks at everybody's lens and puts the whole picture together for someone who's looking at this series and getting educated through this series. And then she'll continue to, every year we do little updates, and we'll do things that help people stay abreast of all the latest and greatest, so to speak, education that's out there. So I am just so honored to be part of that. And I got to electronically meet the other faculty members last, like 2 weeks ago now, when we did that. And it was just so exciting, to learn a little bit more from each of them and feel like I'm a little more grounded in this education, because I've learned all the little pieces of how they look at it, right? So that's another project. And then I'm working on an education piece for athletic trainers. I'm doing a part of a module system for them too, which is kind of what's happening more now. Is I'm so excited that the interdisciplinary care model is getting stronger, that a lot of these groups are now looking at, how do we look at a component from every single group. And so those who are being educated earlier now, or earlier in their education, I should say, they're learning it from the lens of many different practitioners instead of their own little siloed field. So I'm excited that we're just about to get that all wrapped up now too. And then aside from that is just all the like different research projects on barriers to exercise in the female. Why are there barriers, especially during perimenopause and menopause, when that is when we should be exercising? That is the important time for us to pick up on exercise and help our bone health and our musculoskeletal health and so forth. So doing a little more research in that field, and learning more about barriers, so we can help people get care earlier and stop the barriers and let people enjoy their life more, right? So it's been so much fun to do things across the spectrum like that, and just keep going with things.
yeah.
Always a little new project, and then artwork, keeping myself busy with artwork, and
Yeah.
it's been a lot of fun.
Yeah, actually, I want to point out to the audience that this artwork behind you is actually yours. I think you said it was it's a watercolor,
Yep,
and
watercolor. Yeah,
it's beautiful, really beautiful.
yeah.
Yeah,
I enjoyed doing it. It's
amazing.
another creative outlet, I'll call it.
So, Ingrid, if we'll include a lot of information here in the show notes for people on all the things that you just mentioned and how to access your book and other programming that you have out there that you've mentioned. But if people want to connect with you or follow up with you, what's the best way to do that?
So LinkedIn, I'm a fair amount on LinkedIn, and I respond to messages on LinkedIn, and it's just been a great kind of a business model for me, or like business opportunity, in that I've met amazing people through LinkedIn. And I think that's been so much fun to really learn perspectives from other people. So I feel like I've learned as much as I've taught through LinkedIn. So that's a great way. I am on Instagram. I'm on Facebook. I'm probably the most active on LinkedIn, then Instagram, and then Facebook. But any one of those methods are great. But I, like I said, I do like LinkedIn as a great way to connect with people.
Wonderful, Ingrid. Well, I'm so honored to have had you on the show today, Ingrid. Uh, just a phenomenal piece of work that you brought forward. I learned a lot of new things, and I'm sure the audience members have as well. Thank you for bringing to the show and to the audience. A different way of looking at things and maybe hopefully bringing some empowerment to people on how they can consider looking at a different way on and understanding more what's actually people are experiencing. So Ingrid, it's just been such a joy. Thank you so much for your time today, and
Thank you.
best wishes for everything that you're doing.
Thank you so much for having me. I had a great time. I hope your audience really enjoys the different things that we talked about. But thank you for having me. I appreciate it.
Thank you, Ingrid. Take care.